We want to welcome Bill Lombardi from Bellingham, Washington. He's operating today with Ashish Pershad, who's not unfamiliar to the Scottsdale, Phoenix area, a practitioner here. And Bill, Ashish, are you able to hear us?
Very clearly.
Very clearly, Dave. Can you hear us?
Yeah. Bob and I were sitting up here earlier enjoying watching you guys beating your chest earlier. But fortunately, the rest of the audience...
Yeah, we were
didn't
get to see that. We were hoping we were imitating one of your partners, Dave.
I think I might know that. Hey, so thanks for joining us, both of you, and we really welcome the opportunity to watch you perform a CTO case. Just again want to introduce our panelists. We've got Bob Applegate, Mort Kern, Doug Drockman, and Steve Yakubov was with us, but and Jim Hermiller too, and we have extended the satellite time, as you may know, to 11:45. So we'll have a hard stop then, but we'll let you get going.
Well, thank you for doing that. I just want to introduce, we've got Ashish Pershad from Scottsdale. I've got Phil Ditello here, who's scrubbed next to us, interventional fellow at Colorado, who's coming up working on his CTO skill set. Actually did his first solo retrograde reverse cart this morning, and we're all celebrating that for him. Got Dave Myers, Dave Scarborough, and Trevor here, our great cath lab team that really supports our CTO program. And if we want to put up the PowerPoint slides, I'll show you the case presentation here. It's always hard to pick live cases. You never know what's going to happen, so I'm going to sort of show you what we've got. So if we can go forward, next slide. So this is a 40-year-old gentleman who had 6 weeks episodes of chest pain, chest pressure, finally had rest symptoms, presented to his local ER, was in transfer to our center. He had a positive troponin. His EF was 40. He went to a stress test demonstrating a high-risk nuclear stress test with a large infralateral wall defect. He then underwent a coronary angiography, which we'll show on the next slide. So this is his right coronary artery. It's unclear whether that's a local bridging collateral. Can you see that okay, Dave?
We can. Thank you.
Okay. So local bridging collateral or whether it's a recanalized channel. Next slide. Then he's got a occluded circumflex marginal as well. So he's got a double CTO, essentially. Next slide. Interesting, then the operator did what many of us historically have done, and it shows a lot of the current failure modes. So if you notice, this is an ad hoc CTO. It's a single guide catheter injection. They're doing antegrade injections, and you can actually see that the wire is actually next to the lumen distally. So for many of us in the CTO space, as you know, Dave, this would be a case where we would just move from a wire-based strategy to a reentry-based strategy. Unfortunately, this operator didn't have that skill set. Next slide. So they continued to struggle, continued to take pictures, and eventually they dissected the coronary and terminated the procedure. Next slide. So he actually followed up 2 weeks later in his primary cardiologist's office, and the note says that he was asymptomatic and feeling well. And when he followed up to get set up for the case, he's actually been taking, on his long-acting nitrate and beta blockers, he's also been taking 2 to 3 sublingual nitroglycerins a day and struggles walking up the hills near his home. So I'm not sure he was truly asymptomatic, but it does show that cardiologists tend to downplay patients' symptoms when they don't feel there's a treatment option available. So the plan today was to do his right coronary, and if that went well, potentially his circumflex in the same setting. So we have the setup shots for today. So you can see he continues to have sort of that local bridge versus probably just a recanalized channel with a split at the distal vessel. Now, obviously, there are a lot of different options. There's no anatomic ambiguity in this case. There is an occlusion length that's less than 20 millimeters, and he also actually has septal collateral. So this is a case where, in our book, you have every option. You could do this as an antegrade wire. If the wire went subintimal like the previous case, we would do reentry. And if that didn't work, then we would do retrograde. And we've prepared ourselves for success because we're not going to sit there and try, and if something goes wrong, fail. Given that, we actually today we're planning just to do this as a bridge point case because everybody has seen people use wires. What we wanted to show is show the technology. So the plan here was to do this as an antegrade dissection reentry with a retrograde bailout, depending on how the case goes. Comments or thoughts on that, Dave?
So,
for the panel?
So that's a great description, and I think you highlighted a number of issues. One is dismissing or discounting the symptoms for these patients who are clearly symptomatic, who, if we think about appropriateness criteria, and Steve Yakubov addressed this earlier in a talk this morning, but this is a patient who's on at least 2 anti-anginal medications, still symptomatic, has a high degree of ischemia, and we have a therapeutic option for this patient. So the one thing I was going to address is you talked about doing both CTOs at the same setting. What would be your criteria for deciding when to go forward and when not to?
Go ahead, Ashish. You want to take that?
Yeah, Dave. So we actually, when we looked at this CTO of the right, we weren't sure if we were going to actually encounter a CTO or if this was truly a functional and we're able to just wire it or just have the boss go true to true. So our plan was to, I think, give the right the first attempt, and of course, if the right went smoothly, which we expect it will, then move on to the circ. Typically, as you and I both know, we usually will probably stage these and not attempt both at the same sitting. So I think this is an exception just because we thought that the right was going to be a functional given the previous attempt, and we expect the boss to go true to true.
And in general, for me, Dave, is if I can do a CTO in 3 or 4 gray and under 150 of contrast, then I think that gives me enough room to do a second in the same setting. And that's one of the things as you become more efficient that allows you an opportunity to do multi-vessel intervention. I also think it would be interesting, as I had a case I did actually yesterday of a gentleman with a double CTO, and he had a 60 to 70% proximal ID lesion, and it actually had been originally referred to bypass surgery for his LA because he had LAD and 2 CTO. So if this gentleman had a proximal ID lesion, would it change the panel? I heard you guys talk about IVUS and FFR earlier. Would that change the approach at all?
Well, let's go down the list. We'll start with Jim and work our way back up. Jim?
Yeah, I don't think so in my mind. A 40-year-old, you hate to subject him to bypass when it looks like you're going to be able to do these 2 totals, and let's say he had an LAD. I don't think it would change my opinion, Bill.
I think up front.
It was interesting. This patient. No, go ahead.
Thanks. Yeah, I was going to say that up front I'd probably FFR the LAD just to sort of identify how severe it was, and then not doing an ad hoc PCI, have a chance to discuss with the patient the options. But I think likewise what Jim said, probably wind up with a reasonable therapeutic option in a young guy to do this percutaneously.
I would definitely assess the LAD to see if it was significant. If it was, I'd consider bypass in our system, and especially if it was older and, of course, with diabetes. If it was negative, then I think the options for a CTO approach are completely appropriate. But I'd just comment that, this is not an everyday kind of occurrence for CTO recanalization. You need to have allocated adequate lab time, equipment, and skill sets. And if you don't, then bypass surgery raises its head a little higher.
So, hey, Bill.
I couldn't agree more. I think this is not a competitive therapy.
Bill,
sorry, Bob, is that you?
Yeah, that's me. How you doing? I will echo Herms's sentiments here, and I think that we would probably, because of the young age of the patient, prefer with a very, I think, detailed discussion, as Doug had said. I was just going to point out that we actually have a mixed audience here today. We have a number of fellows who are part of a training course, and I am certain that they are hanging on every word that you and Ashish are going to have. And I noticed that the language that the CTO operators use is English of sorts. So anatomic ambiguity, I'm not sure refers to gender, but perhaps a lesion characteristics that you might explain to us in more detail.
Yeah. So when we talk about anatomic ambiguity,
or proximal cap ambiguity,
what we're trying to tell is, can you tell where the artery is going from an antegrade perspective, yes or no? So if you know where the vessel's going, then you do not have ambiguity. If you have no idea where the artery is running, then you have ambiguity. And basically that helps decide whether you go antegrade or retrograde as a primary approach.
Just one other comment about attempting 2 vessels ad hoc at the same time, or attempting 2 CTOs in the same sitting, or 2 sittings at the same time. We have 7.5 frames a second here, which is another huge plus. If labs that don't have this may be limited by their radiation dose, but here, because of 7.5 frames, we could easily be able to do both in the same sitting. without too much trouble. Contrast would be the limiting factor, but he's 40 years old, has normal creatinine, is not a diabetic. So I think all of those have played into consideration.
That's a great comment.
All right.
I think all of us, at least as CTO operators, we have limits on our contrast and our radiation exposure for when we terminate these, and going to 7.5 gray makes it almost uncountable when for us to stop a procedure based on radiation exposure. I just want to make one comment to Mort's issue about FFR, Mort, is that because the LAD would be supplying collaterals to such a large territory, including the right and possibly the circ, that FFR could be abnormal, as you know well, and then after recanalizing the CTOs, it could potentially be above the ischemic threshold. I won't say it could be normal, but it could be above. So the decision-making around FFR, I think, needs to take into the context the amount of myocardium supplied by the target vessel as well. I also think that this is a case that's a little bit outside the context of clinical trials about invoking diabetes and the FREEDOM trial and things like that, because this is exactly what we're talking about. This is clinical bedside practice. This is a 40-year-old young gentleman who can adhere to dual antiplatelet therapy, who has relatively focal disease, albeit complex disease, and I think his long-term outcome would be very good if he's successfully recanalized. I think the big issue is going to be around completeness of revascularization. So that said, we want to talk about your algorithm, and we'll get Ashish or you, Bill, to do that, but let's get you started here.
All right. By the way, the double CTO that when we got done actually fixing both his lesions, the FFR, the LAD was 0.82, so we chose not to treat it. So I've already got a cross boss down close. Little puff. I'm just going to lead the wire into this channel. Integrate puff. There we go. I'm just going to take the cross boss catheter. You can see it just jumped in, so I'm going to pull the wire back. Now, if you can look at my hands, there's a little torquer here. You use the little white and the little black thing to tighten it on and loosen it up. We slide that down about 3 or 4 centimeters from the end, tighten that up, and then I'm going to spin my hands. Now, for those in the audience, you can watch the fluoral, but actually watching the hands is a more important thing here. And so what we do is we spin very quickly and sort of gentle pressure forward while we spin.
The AL guide here is providing us great support.
And it just jumped. Did everybody catch that? We'll fluoral store that. So it got going. Let it spin. And again, this takes no skill. For any of the operators, there is absolutely no skill in doing this. It's spinning and pushing. I'm going to take a picture from a retrograde just to see if the filling's better. I'd like to avoid. So we're going to take and set up here. It's a little off. Okay. And you notice I'm working in 7/2 frames. That's why it's a little shaky.
Bill, while you're doing that too, describe since we didn't get a chance to go through it, just describe the distal tip of the cross-bus catheter for us too.
Yeah, I'm sorry. So it's a 1 millimeter ball-shaped catheter. And essentially what I tell people, in my opinion, is it's an elegant knuckle. It's a blunt dissection tool that 30% of the time will go true to true, which may have done in this case, or 70% of the time will go subintimal, and that way we can use it for entry. And this device will not perf unless you do one of two things. One, you lead it out of the artery with a stiff guide wire, or you track it out an unrecognized branch and don't realize that and run out the end of the terminus of the branch. That's its failure modes. But other than that, you will not perforate if you leave this device in its home. And that's one of the nice, safe things, and it's really nice for working long CTOs. So, Dave, it looked like this jumped, and I can't tell whether I'm subintimal or not, but one of the ways to sort that out is we use a workhorse wire.
Exactly. We have a pro water in there, so Bill's going to actually see if it'll just find its way. And if we're in the true lumen, that's our answer right here. So we don't really have to make an injection and go that route.
I don't know if that feels all that good. Nope, I think I'm back where the other operator was. So I'm going to go a little bit further with the boss here. Can I have that Miracle Pro 12, please? Take another picture.
Yeah, so it tracks nicely down, and it may be tracking in the true lumen, as you say. It may be tracking the intimal plane, but the way it's advantageous.
Yeah.
Do you guys have a comment on the influence of the prior mode of failure where that operator had potentially hydraulically expanded a subintimal plane there, and whether that's healed or whether you have to be sort of wary of that as you're choosing your technique here?
Trap balloon. I'm sorry, I missed that.
Just wondering about
Doug, what was the question again?
the prior operator failed and created a somewhat extended
Yeah.
dissection plane. Has that healed now, or does that influence anything that you foresee in terms of your technique and where your wire and crossboss may be traveling?
Actually, it doesn't bother me at all. In some ways, it's an investment procedure. You know, for us, for us, CTO is not normal intervention. So a dissection actually is a good thing. It's your friend. And so the fact that there was one there before, the odds are I'm going to go back in it because as much as we talk about them healing, they rarely do actually. And it's where we want to be because being in the subintimal space is not necessarily a bad thing. So this wire is behaving like I'm in a false space. That one feels, no.
Could you tell us what an
Let's just take
investment
a picture of
procedure is?
Ashish, you want to talk about investment procedures?
So, in a situation where
I'm in.
we're in the true, did you see
it
that?
went true to true. The boss went true to true. Everybody see that?
Was that a
Everybody see
pilot?
I'm in that?
No, it's just.
It was actually a Miracle 12. I was getting set up to do reentry, and it actually was in the lumen. I just don't have enough bend to get it to take the corner into the other branch.
Bill, you want to comment
Yeah, I'm
on
just
the
gonna leave it. I'm gonna
use
trap
of
it out.
biplane angiography for the CTO versus your single plane in really trying to help you demarcate if you're in the true lumen or not? It looks like feel of a guide wire really is almost trumps anything else you're going to look at.
It can. You know, we've tried really hard as we've built up the CTO community, and this technique is to minimize the number of things that require feel. Biplane is nice. If you're in doubt, you know, it's nice to be able to look in two orthogonal views because it's easy to get tricked. But in general, to me, the biggest limiter is that biplane helps with his contrast. And in general, that's really not a rate-limiting step for most of us in the space now. So what I'm doing now is trapping.
Does
So I have an
everybody?
eight French guide. We've got a 3-0 balloon. Can you guys see that in the guide at the tip of the guide there? So I've pinned the wire on the other end. So I have an over-the-wire piece of equipment on a short wire, and Ashish now can pull
Without being on fluoro.
without being on fluoro to save radiation, and allows you to work with short wires on over-the-wire gear. Can I get a 1520 OTW balloon, please? So biplane, I think, can help you sort out, because the historic issue has been wire is subintimal and subintimal is bad, and I think we've eliminated that from the discussion. And once you eliminate being a luminist, which is you're a wire-based operator, which is I'm going to take a wire from lumen through what you think in the occlusion is the lumen, back out into the lumen on the far end, and move to a hybrid-based approach, which is really based on architecture, which is all you have to be is within the architecture of the vessel. It allows you a lot of freedom and a lot of simplification and efficiencies in the procedure. And as you brought up, the biggest thing with architecture and orthogonal views help with that in biplane is it allows you to ensure that you are in the architecture. Guide wires and devices rarely hurt people if they're in the architecture. Where people get hurt is a stiff, sharp guide wire is stuck out an artery and then followed with a device. Dave, do you want to make any comments on that with you guys' experience at Piedmont in regards to sort of the architecture lumen discussions?
Yeah, I think we're a center that, as you know, is about 35% retrograde. So it reminds us, first of all, that the majority of these cases, no matter where you are in the world, are predominantly antegrade, like this case. And the number one wires that we use the point technology in about 25% of our cases, either a combination of crossboss and Stingray or Stingray alone. The Stingray balloon we should introduce to the audience is a special kind of flat, almost Stingray-shaped balloon that enables reentry from the subintimal space. I think this really has excluded the need for historical, now becoming historical, rapidly historical, outdated techniques like parallel wires, because we really, you know, we're really moving down quickly and not spending our time working through the CTO itself. We're either going to go lumen to lumen or we're going to go subintimal and then re-enter downstream. I guess, Bill, that and Ashish, maybe one of you could address something that and I think this case kind of shows you this is a case where an operator was unsuccessful at doing this for a potentially variety of reasons, but you've made this case a 5-minute, crossing case here, and now may move on to the other CTO for that matter. So I want to ask you to address for the audience something that we've collectively promoted as this algorithm for CTO, because I think there's a sense of foreignness that this can't be done at all institutions. And look, you've got a great fellow from Colorado who did his first reverse cart this morning. So it's case in point that all operators, most operators, can be doing these kind of procedures, and it's simplified now, and the toolbox is simplified, and the procedure is simplified. And you talked about, Bob mentioned anatomic ambiguity and lesion length, and you really referenced the 4 key elements of this algorithm, but maybe not in such a formal way. So can you talk a little bit about the algorithm?
Yeah, so sure. So Bill, you want me to, or you?
Yeah,
want
you can do it. I'll just
So
keep
yeah,
working.
so first element, as Bill mentioned earlier, was that whole business of proximal cap, ambiguity versus non-ambiguity. The second thing we talked about is the lesion length. If it's less than 20 millimeters, we generally would start with a wire-based strategy. But if the lesion exceeds 20 millimeters, then the likelihood of successful wiring with just a wire-based strategy dramatically falls. So at that point, we commit to something called dissection reentry. To simplify the terminology, we've basically converted dissection reentry as the default term, both for antegrade and retrograde dissection reentry. So instead of words like cart, reverse cart that confuse operators and make it like this whole big mumbo jumbo, we've now decided that if anything that's greater than 20 millimeters in length as far as the lesion length, when approached with a dissection reentry strategy, it's either antegrade or retrograde. If the interventional collaterals are appropriate and suitable for you to use retrograde, or if the vessel is at a distal cap, the distal is at a bifurcation, or the distal bed is diffusely diseased, then we default to going retrograde. If none of the above are present, then we would just go antegrade with a dissection reentry strategy using the bridge point system. And that is not the same as a star or a mini star or a last, but instead is actually a very exquisitely controlled reentry where we can actually identify the site of reentry and are able to reenter with the Stingray balloon and wire, which unfortunately we couldn't showcase in this case, but hopefully we can in the circ if we end up needing.
Yeah, Ashish, so just to
I'll make it even,
4 really good elements
actually,
here.
Can I throw something in, Dave?
Lesion length, proximal.
I'm sorry, what?
I was just saying, just to review for you, for the audience here, you highlight 4 good elements: lesion length, proximal ambiguity, the quality of the distal landing zone, and do you have interventional collaterals for a retrograde option? And if you go through that algorithm, which has been published recently too, I think it really standardizes how we do the procedure. The other thing I was going to just mention is that, there you go, is that you were talking about subintimal or star techniques and large dissection techniques, and I think there's a misunderstanding that we probably need to clarify about this, as exemplified in a recent publication, I think in JACC, where the occlusion rate was like 50% for subintimal techniques. Well, that's when you make these large, major patulous dissections. What we used to call star, where you've dissected the entire artery. And this is not the same thing. This is a subintimal technique, but it's a focal, localized reentry technique that's very different in character than that.
Because if you notice, Dave, look at the branches. Here you have the RV branch, you have the branch in the proximal right, and you have the distal bed is exquisitely preserved. So this is completely different from a star or a star.
And there are a couple other things in hybrid, which is what we're teaching people now is not skill, it's skill sets. And the skill sets are how to do antegrade reentry with bridge point and how to do wire collaterals and do retrograde. If you can do those, you can do most of the anatomy. And our major goal in this has been is to stop treating this picture. This picture is a technical how we're going to fix it. And, as we listen to people talk about FFR and IVUS guided and all this stuff, that's great. What we want to do is treat patients, not angiograms. And historically, the community has treated angiograms. And to me, the angiogram is just, well, I was right. It's a true positive test. And now I need to make a decision. Am I going to do percutaneous revascularization or surgical revascularization? That's fine. Go up there. We're going to end up with some diffuse downstream disease, but as you know, these grow about 30% after you fix them. So 14. So that's really the goal here, is to get the audience and get people in the room, is stop treating angiograms, which is what we've done historically, and let's actually start treating patients and not using excuses to not treat people. Because, I did a lot. I was a heart failure transplant guy long ago. I hate to admit that. But it was all about physiology. And I can tell you the myocardial cells, when they get ischemic, is because they get lack of oxygen. And they have no idea whether that lack of oxygen is because the bypass graft has a lesion in it, whether they have a 50 millimeter, 50% stenosis that's FFR positive, a 1 millimeter CTO, or a 100 millimeter CTO. All they know is they're not getting oxygen. And we've got to start, so I'm hoping is we'll see people treat patients and not the angiograms. Because technically they're not,
So Bill
as you
Morton,
know, Dave, there are not a lot of lesions we can't treat.
Bill Morton and I have been discussing this, and I think my interpretation of what you're saying is that, we need to go back to the patient that has chest pain that's refractory to medical therapy, and that's an individual, so the patient needs to be treated. You're saying that the skill set, that the technology in CTO has come so far that you don't have to look at the angiogram and say, I can't do that, therefore I can't treat this patient. Is that fair?
Yeah, that's really fair. That's what we're trying to get to. And do we get 100% of these? No. But, I can show you a lot of our colleagues early on. One of the things I noticed is that they were cherry picking. And that means they were treating what they can, not what they should. And I think, the interventional community needs to do a better job of treating what they should, not what they can. Now, I find the AUC interesting. If I have a patient with an occluded right and a high-risk stress test with inferior wall ischemia and a 70% lesion of the LAD, and they're on one drug, and you stent the LAD, that's an appropriate procedure because they don't require localization of the ischemias. You don't need to FFR it. You don't need to do anything, but that was okay. But if you fixed that patient's CTO, it's uncertain or inappropriate. And that just doesn't make sense. And so that's what we really want to give people is I want people so skilled at fixing coronaries that they don't have to make the decision based on their skills. They can make the decision based on what the patient truly needs. And I think that's what we're trying to get to in this CTO community is that skill set.
So
it's
Bill,
teachable because
you learned it.
Exactly. No, it's true.
And Kenzari learned it, and I learned it.
So one of the questions I wanted to ask early on was really between Ashish and you, and maybe Doug, since he's the youngest of the interventionalists up here. How would you have rated this in terms of difficulty looking at the angiogram?
And this the one we just did?
This right coronary?
That's about as simple and straightforward as it gets, and the success rate should be 110%. I
would echo that.
They didn't give me a cytal guide.
And Doug, I'm curious what your thoughts are on the 110%.
Didn't give me cytals.
Well, from my perspective, as sort of an emerging CTO loyalist, I would say this would be high on the difficulty schedule here for our perspective at the MGH presently. But seeing...
That's going to change in the next year, though.
Exactly, and seeing how extraordinarily skilled hands can make this look like it's a straightforward operation is remarkable for all of us.
First of all, I want to make the comment that...
sorry.
Well, I just wanted to make the comment that Doug and I actually were classmates together, Bob. So despite me having gray hair, I'm the same age.
Mea culpa.
But no. In all seriousness, let me just go back to. I think Doug's comments are relevant though because it's reflective of many practitioners. Is that I still think to Bill's point, we're in this mindset about what the angiographic appearance is, and in part that's a fair statement because historically all of the predictors of procedural success and failure in CTO revascularization had nothing to do with patient age, gender, creatinine clearance, things that we think about as other PCI variables, but they had to do with the angiographic appearance, bridging collaterals, calcification, ambiguity of the proximal cap. And now with the standardization of the procedure and the tool set, I think all of those issues are those dictate strategy, but they don't dictate whether to do it or not.
Yeah. Bill, you think you have an edge
I
dissection
think that's
there?
really distally or proximally. Distally is spasm.
I think it's wire
It's
spasm.
spasm, and I think that's spasm, spasm, and spasm. You know, it's always hard to size the stents because we know they're going to grow. I mean, this is a 40-year-old male. A 3.0 stent actually should be too small. And so it's sometimes hard to pick appropriate size stents. I think I've just got spasm. Once I get this opened up, a little flow, we got damp, it'll be fine. But I do think, you know, as we talk about the degree of difficulty, I mean, the case we did this morning was a 15-year occluded post-cabbage right coronary. It was about 20 millimeters long. And most people would have said historically, you know, this can't be done, even though the guy's had 4 admits for chest pain and inferior wall ischemia on his nuke. And we took somebody who's in their training, and you can learn to do it. And I think, you know, as we're talking about this, Dave, it's the training has been really critical. And because we have an algorithm and because we can have a consistent approach, and now that there's enough teachers and centers around and people who want to teach, and, you know, between the website, ctofundamentals.org, where you can get a lot of the language, semantics, and techniques shown to you, and then going to these workshops. Is it good? Yeah, that's it. It's got it. Low proximal disease. That there's a very high degree of people coming out of the box and getting successful. The next piece, though, you have to is manage expectations. Are you going to do what I can do in your first 10 cases? No. But, you know, Ashish has done 500. I've done 500. And that might be, I think, for the audience and the people there, Dave, talking about the Piedmont experience in regard to the learning curve of CTOs. I don't know if you think that would be helpful to maybe make some comments in regards to that.
I think no, I'd be happy to comment on that. You know, we do, I think, in the past year and a half, of something like 350, 360 CTOs, and to begin with, it's a collective effort among 5 operators who have dedicated themselves to training or education in the CTO space in different ways. We've set guidelines for terminating procedures, although, like you say, our overall success tracks at well above 90% now. About 38% of the procedures are retrograde, the remainder antegrade. And I guess I also would just comment that to Mort's point at the very beginning about you need to have skills, and you need to have skill sets, and you need to have a dedicated time in labs, is that the skill sets I think we've addressed well, but when you think about a cath lab volume nationally declining for PCIs 13% last year and an annualized decline of about 7% year over year, this has been a way, in some ways, and not just specific to CTOs, but left main and complex disease in general, of mitigating that decline. And you typically see more in hospitals, cath labs that are sitting dormant. And I think one of the other issues has been that CTOs have been attributed without any evidence basis as a cost disincentive. And one day this is going to come out in its publication, but it's been accepted and we're waiting for it. But, you know, our economic analysis of this shows that really these procedures represent a contribution margin to the hospital that is exactly the same as almost identical to a non-CTO an elective non-CTO PCI procedure. So despite using an average of 7 guide wires per case, and despite using an average of 2.7 stents per case and more balloon catheters, because of differential billing, and in part because these patients come in like this gentleman did for Bill, a very singular focused purpose that they're going to go home the next day, barring any complication, and so the overall cost contribution margin is really the same.
Can I just add a comment? I think,
Dave, the other point is there's a windfall.
Hey, Herms, are you there?
Yeah, sure am, Bill. So,
hey, Jim, do you want to talk about your guys' experience at St. V's in the last year and what's going on there?
Yeah, so we're kind of trying to teach old dogs new tricks, right? And you know, we've been fortunate to work with Bill and his gang, and Tony Martini in particular sent over and helped us out. And we've gone from really a fledgling group to, I think we've really gotten good with antegrade and re-entry and now we're sort of trying to tackle the retrograde and get good at that. But really concentrated the procedures in a couple of operators' hands, dedicated time for CTOs, and I think spent the time to try and get this right, as Bill has told us how we should do it.
So just as a neophyte to the area myself, our young colleagues are undertaking the same program Bill's recommending. I think what we're witnessing here is a next advance in interventional techniques and procedures to provide more revascularization for patients who wouldn't be able to do that, right? So I think the CTO approach is critical.
Yeah, because again, what we want to stop doing is treating the angiogram and treating the patients, and it is critical. I think, Aaron brings up the acuity data, and I think it shows a real problem with interventional cardiology. And that challenge is that as the syntax score got higher in acuity, we got worse. Matter of fact, the delta syntax score was less and less. And Dave, or you guys know this data better than I do, but that's really a bad sign. The fact that the more complicated the coronary disease, the better we should do, not the worse. And that's something that I was very concerned about. That data was we're not. Oh, you shaped it for me. That to me, I don't know if you guys want to comment on that, but I think that's one of the big deals. And I think there was a recent paper out of the syntax groups showing that if you had complete revasc, irregardless of method, you had a better. Your event rate was much lower than if you had incomplete revasc. And I think that goes back to not getting into surgery versus intervention. It's about getting revasc. So if the surgeons don't graft something, we should fix it. And if we don't fix something, then we should think about our surgical colleagues. Puff. So I've got a little branch here at the proximal cap. I've just got to sort out.
Hey, Bill, bring us back to where you were when you completed the right coronary. The thought that you had about leaving that, the distal vessel, what looked a little ratty, and perhaps some people might have said, there was some uncertainty about the extent of the severity.
Yeah. So go ahead, Ashish. It's fine either way.
Yeah. The answer is, we usually tend to be minimalists at the end of these type of procedures because of this whole phenomenon of positive remodeling that takes place in the distal bed, and vessels have been shown to grow by 20 to 30%. And so if you re-angio these people and bring them back, the plaque burden is minimal, which it looks like is the case here. This vessel will remodel in a very favorable way, and we just tend to leave these alone, especially when it's at that bifurcation. And the last thing we need to do at this point is get into a bifurcational treatment strategy at the PDPL bifurcation. I think leaving that alone was probably the approach that most of us would take.
I really, my view is fix a CTO, leave everything else alone unless you're really forced. Again, I don't want to treat the angiogram, I want to treat the patient. And if I need to go back and do more, if he's still having issues, it's a very simple thing to come back and do. My experience has been, and the IVUS data has been, that most of the time they actually do very, very well, and so you don't need to worry about it.
And so as long as there are outflow, there's no huge number of branches, terrific outflow, you're going to be fine.
So I was going to move on to the circumflex, if that's okay, because we're at a grade now of total radiation.
No, go ahead. Please start the circumflex. We saw you had to wire down.
Yeah.
So let's talk about the circumflex too, and let's just talk about a few fundamentals. But it's not without commenting that for these cases for a femoral approach, we typically, as you do, use 35 centimeter sheaths for extra support. And I think another fundamental is to, with very rare exception, always do contralateral injections. This is a mainstay for us in the far majority of the cases, because even if you don't think that there are collaterals, once you shut down the antegrade collaterals with a dissection or something, I think having that contralateral imaging is going to be quite advantageous. So Bill, in this case too, the crossbus looked like it was tracking down the marginal branch. And instead you were able to purchase with a wire into the circumflex, and now you're with the crossbus.
Yeah, so what I did was a wire redirect. So one of the crossbus issues is it doesn't get through the proximal cap, or you can't get through the proximal cap, and so this is a wire facilitated. So I've stuck a wire, I've got it in, and again, if we look at our pictures, and I think we got it, here we go, there's a picture of this. you know, I don't really have a lot, in my opinion, of anatomic ambiguity. There's a pretty blunt cap. There's a side branch there, but it's pretty reasonable where this artery is traversing. The distal cap, that you could say there's a bifurcation at the end, but it's into a little AV nothing vessel that really doesn't supply into the LV mass. It's really going to be about this distal OM territory that matters. So I have a reasonable landing zone. I have no proximal cap ambiguity, and it's longer than 20 millimeters. And the interventional collateral, there is a collateral from the diag over to the OM, but it's a pretty high-end collateral, and I would suspect for a lot of people in the audience, it's not even something doable. And that's, when we talk about collaterals, one of the most important things to talk about is not, is it a collateral that Bill Lombardi can do? It's got to be the collateral that you at the table can do. Otherwise, it's not in the discussion. So that's why, in this case, we're taking an antegrade dissection reentry as a primary strategy. We've facilitated the boss getting into its home by using a wire that we know is very unlikely to cause a perforation, which is the Pilot 200. So let's just make sure we're through the cap with the boss, because that's all I really need. So now the boss is in its home. So I'm going to pull the wire back, and we're going to, again, see if we can get the boss. We've got to watch our guide.
Watch his hands, rapidly spinning. I don't hear any ratcheting sound, so he keeps spinning it until it either makes that sound or...
Interesting.
So this is another little trick. Usually if the boss struggles to advance,
It's in the true lumen.
it might be in the true lumen here, because I think that
Learn some more.
if you're in the subintimal space, it should usually just fly down in the absence of calcium.
So I'm just, again, trying to facilitate with a wire passage. And I don't care where this wire goes, because I know it's going to stay in the architecture. And so as long as I'm in the architecture like that, I'm okay. This is walking like it's in the lumen.
Can I ask you about that architecture? You mean between the wall of the artery and the lumen, not between the adventitia and the wall. Is that right?
Pretty much. I mean, honestly, I'm not smart enough to tell you where the adventitia, the intima, the media, the occlusive segment, is it within the adventitial boundaries or not? As long as you're inside the adventitia, you're good. Can you take a picture? I think I just wired this.
Yeah, I think we just crossed true to true.
Nope, subintimal. Okay. Great. That's right where we want to be.
But that's
okay.
that's a great location here, right above it, to re-enter.
Yep.
Yeah, Bill, to your point, I think
I'm gonna try
the
this out.
far majority of the cases at some point, even when we say they're lumen-to-lumen crossing, that we're subintimal at some point. We're in the architecture, but not within the actual luminal construct of the artery.
And this is the efficiency piece, which is because I don't care, I can cross long distances quickly. So the boss didn't go, the pilot did, the pilot's subintimal, but I'm still 2 minutes into the case. I've crossed 40 millimeters, and I'm exactly where I want to be. And, you know,
this is usually
don't be afraid. This balloon may be done. I need a new trap balloon. This one's
This is usually the point where most interventionalists will call it a day and say that they failed when they're subintimal with a wire. But actually, it's actually a lost opportunity, especially in the CTO world, because you can use that now with the current technology that we have and win almost every time.
And this is for people learning. I think one of the biggest barriers is you have to realize this is not interventional cardiology. This is now CTO. This has as much similarity to doing interventional cardiology as TAVR does. There's catheters and there's devices, and that's about it. And you really have to sort of, and I think as Jim brought up the old dogs, is you have to unlearn a lot of bad habits, which is dissections are good, subintimal is good, pushing hard is good. You know, all of these rules that you hold dear to a normal intervention are actually completely wrong within the CTO space.
So Bill, for most interventionalists, they probably would leave the wire that they have subintimal, bring another wire down, and begin to probe again. And can you just address not the fact that you're going to show us the technique of using the subintimal reentry, but of using another wire and just continuing with the parallel wire technique?
Well, again, the parallel wire technique was built by people who want to do lumen work. And their belief is in a 30 millimeter CTO, they can. I need a 1.5 RX balloon. I got to dilate this channel. the history of parallel wires was the antigrade wire tells you, or the wire that's there tells you where not to go. So you take a second wire, diverge from it, and come down and can re-enter. And in a little 10 millimeter or 20 millimeter CTO, that works. When you start dealing with 50 and 60 and 80 millimeter CTOs, having done a ton of those before we developed this, I can tell you is the likelihood of success
unpredictable, very difficult,
and impossible to teach because it's all feel. And so the idea behind this now is a wire subintimal is a good thing because we have an ability to manage it. Historically, we didn't have a device that could manage it. And that's where retrograde was really developed by the Japanese, was to manage a subintimal wire because they recognized that parallel wire and IVUS guided reentry were limited and didn't work. And so that's where the history of retrograde started, was to deal with just this situation. But now we have a technology from an antigrade perspective that can manage it. And I think it's a big hurdle for people to get over, because what happens is they come back and they redirect and they do parallel wire, and you actually end up wrecking the vessel.
And actually,
because you make it
enlarging
the dissection and making things worse.
Hematoma.
Leave it there because we'll need it to get the stingray in. So what I'm doing now is just making sure I balloon. Let's go up there. I'm just going to balloon my channel to make sure I can deliver the stingray balloon to where I want it. Just go to like 4 or 6. I don't want to go crazy here. But I think that's the big issue, Bob, is this doesn't mix well with a wire-based strategy. You really have to commit to it and just say, I'm going to do it and do it this way. And it's, for those who've done it, learning it has been challenging, but it's not impossible. And I think that's the, if you try to teach somebody how to do wire-based strategies, it's an impossibly difficult thing to learn. I know, Dave, you grew up in that world. I grew up in that world. I mean, what is your sense comparing what we used to do with guide wires to what we're doing now with this type of strategy?
I think the issue really evolves around predictability. So the wire-based strategies of IVUS-guided reentry with a wire, of parallel wires, mini stars, limited antigrade subintimal tracking, while they may be successful in selected instances, the predictability is a guess, is guesswork. And here I think this is faster. It limits the procedural time, which has advantages with regard to contrast and radiation, and it's much more predictable.
Yeah, and not only...
Yeah, I think it's one of the commonest benefits. Go ahead.
I was just going to say, Bill, predictability and efficiency. I think one of the barriers to CTO, we just don't have time in the U.S. to sit around for 3 or 4 hours like we see many of the expert Japanese operators. And I think your algorithm and your techniques, make it efficient. You can get this done in an hour or an hour and a half, something that I think practicing interventionalists in the U.S. can take on.
Yeah, and I think that's the whole point, is what we noticed a lot of the experts, and it's not just Japanese, it's globally, is a lot of these people were teaching wire-based strategies, and they are masters. They are very skillful with wires. They have great success rates. But I personally, and what Craig and Aaron and several of us in the U.S. noticed was, one, they were cherry picking. They would refuse, take it down. They would refuse to do certain cases, which we think just leave it that way. If we're here to treat patients, that shouldn't be the case. You shouldn't base it on the angiogram. And the other was, it took a long time, and it was almost impossible for anybody to learn. And in some ways, I'm not sure they wanted people to learn, because it helped protect them as the experts and masters, and that this is magic. And, what I would tell people in the audience is, this isn't magic. This is really, that wire really subintimal?
So this is a little bit like watching Oz behind the screen, Bill. You want to tell us a little bit about what you're doing here?
Yeah, I'm sorry.
Are you going to have to?
Well, I'm delivering this thing. I may actually be in, so I'm going to sit here, because the wire got all of a sudden really free. I can't see my vessel at all anymore, which is the real problem. But boy, that wire feels in.
I want to look at the angiogram from before and just see.
That's in, man.
That's in.
Unfortunately, that went in too. Gosh darn it. I was bringing in the stingray balloon to
have
re-entry.
Just pull it back and knuckle it, and just so we can see the re-entry. Obviously, I'm just kidding, but so you had the stingray balloon down there, right past the proximal cap. It looks like, right?
Yes.
Yeah, exactly. And I just think either we were in the lumen and we just couldn't, it was underfilled, or I found.
Was that a pro water wire then that just you had as
That's
a
a pilot.
This is actually a pilot, Dave.
Okay.
And we're finding all these branches. It looks like we're there.
Yeah.
So I'm going to take this out. Sorry, guys. So it looks like we're going to do a double CTO. You got it. You can walk it out. So I didn't get to do reentry. So yeah, so I ended up doing two, a Boss true to true and a wire case true to true. And, we just did it in 50 minutes. And these are cases most people wouldn't even tackle. And again, this is not a unique skill. Ashish, we could have swapped places. What? Yeah. Ashish and I could have swapped places, and the same outcome would have occurred. I could put Phil here. It would take a little bit longer, but we can coach him through how to do this. And I think for people wanting to learn it it's learnable. It's not easy. It's very, very hard. It's probably harder to learn than TAVR or left atrial appendage closure. Let's drop the trap. We want to get that over the wire balloon back. Yeah, it's a Pilot 200. I don't want to work on a Pilot. But I think that's the key, as everybody on the panel is starting to say, is if you want to learn this, Phil is the second fellow that we're training to do this. There was a fellow out of Stanford named Dave Daniels, who's now he's 7 months out of fellowship. He's done 100 CTOs. He's doing reverse cards. Actually, he did a really interesting case a week ago. He was doing a non-CTO of the right. He it was a distal bifurcation. He stented the distal right to the PL, lost the PDA. The patient started having chest pain and ST elevation, and he went in retrograde and salvaged the PDA retrograde. That's a guy 7 months out of training because he's worked really hard to learn it. So I think one of the messages for the people in the room is if you want to learn it and you want to put the work and effort in, you can learn it now. This is not magic. And we are trying to demystify it. And, Bob, your comments are well appreciated. We're sort of working, it's the Oz down with the trap one. And we want to demystify it. And you can't in an hour sort of demystify it. But if you want to learn it, go to ctofundamentals.org, do the website, get yourself hooked up to come to one of the practical workshops that we're putting on basically twice a month right now. And you can go and watch us do 8 cases over a couple of days and talk and learn it and learn how to do it. I know, Jim's been to one of the courses here. I don't know, Jim, do you want to comment the value of the live workshops?
They're invaluable. You can't get on a website and learn what you do watching Bill and his colleagues. The nuances, the subtleties, those 2 days there, it's going to the Dalai Lama to sort of learn something spiritual. And actually where Bill lives is maybe not quite as close as the Dalai Lama. But anyway, it is invaluable. And then what happens is you get somebody come into your lab and proctor you to do this. And you put all that together, and you start to make some headway.
I'm right.
Well, ultimately, I think that this is very much like the radio revolution. I think that's sort of moving across in the access field, and we're seeing it now incorporated in the training programs. And I think as some of the the educators within the training programs recognize the strength of the approach that's being outlined. You're going to see it in the training program. So it's not going to be postgraduate training. It's going to be incorporated into the training program. And I think that's when we know a technique is really evolved to the point where it should be mainstream.
I think you're right.
I agree 100%.
The learning curve has never been shorter. Right now, we've got just to reiterate, the CTO Fundamentals website. We've got these training programs that are regional. We have the SCAI programs. We have another one coming up in June that Bill and I and Ashish and others have been part of. But you see it with a fellow who's training right now. So like Radial, they want to differentiate themselves as they move out for seeking jobs and practice. Senior interventionalists, people at all levels of their career, need to find a way to differentiate themselves or expand their skill sets. And so when we do these programs, we see that you have the wide range of operators. You have people, Jim termed them the old dogs, and you have young folks as well. Bill,
there you go.
We're going to stay with you for another 3 minutes or so.
Okay.
You've done 2 CTOs in less than an hour. Pretty standard practice for most of us. And and just tell me, how much contrast and gray have you used right now? What's your gray count?
You guys should see my new lab. I wish I could get a picture of my screen. So I just got one of the brand new Philips flat panels with 7.5 frames. So we're at one. You just pull. We're at 1.5 gray total, and how much contrast have I used? Contrast, guys? Total for the whole case.
2040 balloon. Is that a 25 something?
So, Bill, while you're working on that, also, you haven't commented on the tandem.
105 of contrast.
You haven't addressed the tandem approach you have, where you have two really experienced CTO operators together. You want to just make a quick comment about the strength of that versus doing it as a solo operator?
Yeah, well, I think is this a 3-0? 2-5. You know, I think the comment. So a lot of the programs that have gotten started have really done it as a double scrub. So you have two doctors at the table on a regular basis, and if you can economically do that, or your practice model allows that, you know, I 100% think that's the right way to do it. These are very complicated procedures. There's a lot going on. There's a lot of different techniques. Don't go too big here because I know how big this is. And so it's really nice to have two people there. It allows two people to learn and work together. And I, you know, I do a lot of, I work as a solo operator in my hospital because of the economics of our practice. But my techs are incredibly good, very well trained, and are a big resource, and we've done a lot of volume. But I think early on, having two operators learn this, working together, supporting each other, building a program is really critical. I don't know, Ashish, you know, you work individually, but when we get to scrub together, it's always so much better.
I think especially starting out, I think it's hugely beneficial because, you know, especially when operator fatigue sets in, you're in a tough retrograde case, and you have these temporary moments of insanity where you get frustrated. You always nice to have somebody next to you that can kind of help things along and prevent you from doing.
I think there's an advantage.
On the other is, you know, everybody
on,
brings something to the table.
You know, even when we still do two operators for all of our cases here, and I think there's an advantage to that if you can if you can
I get a
make it happen in your model.
2.538 element? I'm just going to drop a stat.
Yep.
So
So
Bill,
again, you can see the whole problem with remodeling.
we're gonna leave you here in about a minute, and I just want to thank you and Ashish
Well, we'll see you guys tonight.
for being part of this program. It's a pretty impressive display of the technology, the strategy, the technique. I think we had a great discussion around the indications as well. I want to thank our panelists too. So this has been great, though, Bill. Thank you.
Great job.
I want to thank the faculty and for having us, guys. I'm glad you enjoyed it.
Bill, can you still hear us?
Hear you, Dave.
David Razek's here, and he was going to make a comment here, but we're trying to get a mic on for him, so bear with us 1 second.
Okay.
Bill, can you hear me okay?
Tell Dave
David Razek?
doesn't need to.
Yeah,
Yeah.
how are you?
Hi, Dave. How are you?
Doing good.
Hey,
that
Dave,
was,
how are you?
Look forward to seeing you guys tonight.
well, that was just, I want to express my gratitude. Every time I ask Bill to do a case, he says, okay, how would you like it? You know, it's kind of like an a la carte menu with him. You want an antegrade, retrograde, you want one CTO, two CTOs. It's absolutely fantastic to see the two of you work together. And there'll be a little bit more on CTOs. And Bill and Ashish are jumping on a plane in about 45 minutes or something, and they'll be here. So if you want to meet with them, talk to them more about the training and whatnot, the two of them will be here. For those who are local Phoenicians, we are very fortunate to have Ashish locally. He's great about helping out, and of course, Bill will be here later as well. So thanks, you guys. Really, really terrific job.
Thank you, Dave. We appreciate it. Dave, you can cancel my car. Ashish is going to take me from the airport.